Imagine experiencing pain so severe during intimacy that it feels like an internal collision, like a really sharp, breath-stealing impact.
Yeah, that's incredibly jarring.
Right. But then you go to the doctor, they run a standard exam, and they find absolutely nothing. No obvious cuts, no surface issues.
And sometimes they even suggest it's just, something you have to live with.
Which is just wild to me.
Yeah.
Today, we're looking at this massive medical blind spot that turns one of the most intimate aspects of human life into a total source of dread.
It really does.
It's a condition clinically known as dyspareunia, or painful intercourse. And while it is an incredibly common symptom, the hidden structural causes behind it are they're so often misunderstood or just entirely missed.
Yeah, and it leaves patients in this terrible limbo. I mean, they know the pain is real, it's physical, it's intense.
Right.
But because the source is hidden in the dark, tightly packed real estate of the pelvis, it just doesn't show up on a cursory exam.
Mm-hmm.
The pelvis is a really complex three-dimensional space, and when something goes wrong deep inside it, the symptoms can be incredibly deceptive.
Okay, let's unpack this, because we are diving into a huge stack of medical guidelines, urogynecology reports, and clinical case studies to solve a very specific, fascinating puzzle for this deep dive.
A really important one, too.
Exactly. We are going to explore the unique structural pain presentations of deep dyspareunia when it's caused by two completely different hidden masses.
Yeah.
And these masses can take up the exact same physical space.
Right.
On one side, we have an active pelvic abscess, which is a pocket of severe infection. And on the other side, we have a chronic pelvic hematoma, which is a pocket of trapped blood.
So you have two entirely different underlying pathologies. They require completely different medical interventions, yet they both trigger the exact same mechanical alarm bell in the body.
And whether you are a medical professional or maybe someone navigating unexplained chronic pelvic pain, or you're just wildly curious about the hidden engineering of the human body, this is going to fundamentally change how you visualize internal pain.
It really shifts your perspective.
It does.
Oh.
But before we put the abscess and the hematoma head-to-head, we need to establish some ground rules about the pain itself. The sources differentiate between two types of this pain, superficial and deep.
Superficial seems pretty straightforward, right?
It is, yeah. Superficial dyspareunia is entry pain. It happens right at the vulva or the vaginal opening.
Okay.
The pain is almost instantaneous, usually sharp or burning. It's basically a surface-level issue.
So like what exactly?
Well, the medical literature points to things like a lack of estrogen causing tissue thinning, or perhaps a localized skin condition.
Got it.
Sometimes it's structural on the surface, like an episiotomy scar from childbirth. When that heals, it can sometimes form a small bridge of scar tissue that just happens to be packed with highly sensitive nerve endings. So that's a friction issue at the gateway, basically.
Exactly.
But the clinical puzzle we are looking at today is deep dyspareunia. So this isn't happening at the entrance.
No, this is a completely different mechanism.
Yeah.
Deep dyspareunia is felt deep in the pelvis, often in the cervix, the lower abdomen, or even radiating out to the lower back and thighs.
Oh, wow.
Yeah. And the mechanical trigger is very specific. It occurs with deep penetration or pelvic thrusting. The clinical term used in some of the literature is collision dyspareunia.
Collision? That is such a visceral phrase.
Hi.
I'm picturing an actual physical roadblock. The patients in these case studies describe the sensation of literally hitting something inside, and it can be so agonizing that they just have to stop everything immediately.
It's an abrupt halt.
But here's the part that stood out to me in the reports. The pain doesn't always stop when the physical impact stops. It can throb and ache for minutes, sometimes hours afterward.
Yeah, that lingering effect is a huge clue.
Wait, help me understand that. If the collision is over, why does the pain keep ringing like a struck bell?
Well, to understand that, we really have to look at the environment of a healthy pelvis.
Okay.
The organs deep inside the cervix, the uterus, the ovaries, the fallopian tubes, they are richly innervated. They have a massive blood supply and a vast network of nerves.
Right.
Normally, they are pliable. They can shift, stretch, and accommodate physical pressure.
Like they're supposed to.
Exactly.
Mm-hmm.
But when there is an underlying pathology, when something foreign is growing or swelling in that space, those tissues lose their flexibility.
Oh, I see.
So the lingering pain is the nervous system reacting to severely irritated, distended tissue that has just been aggressively shoved against a rigid mass.
I was actually trying to visualize this while reading the notes.
Mm-hmm.
Think of the healthy pelvis like a perfectly packed suitcase. Everything fits.
I like that.
But if you introduce a swollen, rigid mass into that tight space and then apply rhythmic physical pressure to the outside of the suitcase, things are going to get crushed. Or it's like the pelvis is a suspension bridge.
Oh, that's a great way to look at it.
Yeah, everything. The uterus, the bladder, the rectum is suspended and tethered together by this intricate spider web of ligaments and fascia. When it's healthy, the bridge sways with the wind. It absorbs movement.
Perfectly balanced.
Right. But if you inject a heavy, swollen, rigid boulder into the middle of that webbing, the tension totally changes. Suddenly, applying rhythmic physical pressure to the bottom of the webbing, like during intercourse, pulls violently on that boulder, crushing the delicate tissues trapped against it.
That is an excellent analogy. You aren't just bumping into an organ, you are transferring force through a structural web that is suddenly holding a massive rigid weight.
Yeah.
What's fascinating here is the sheer scale of the issue. Chronic pelvic pain affects somewhere between 6 and 25% of reproductive age women.
That's huge.
It is. And it accounts for up to 40% of all gynecological laparoscopies, which are surgical procedures to actually look inside the abdomen.
That is a staggering amount of surgery for something that often gets brushed off as just a vague complaint.
Absolutely. The overarching theme in all these medical guidelines is that deep dyspareunia is a symptom. It is not the disease itself.
Right.
It is a structural alarm bell telling us that a foreign mass is occupying space and altering the tension of that internal suspension bridge you mentioned.
Which brings us to the first culprit setting off that alarm, the active pelvic abscess. I started thinking of this as the inflammatory fire.
Fire is a good word for it.
Because this isn't just a physical weight in the webbing, right? It is a highly infectious, volatile pocket of pus. How does something like that even form deep inside the body?
Well, it almost always begins with pelvic inflammatory disease, or PID.
Okay.
This is an infection that starts low and ascends. Most commonly, it's driven by sexually transmitted bacteria like chlamydia or gonorrhea, though other vaginal flora can sometimes be responsible.
So it travels upward.
Yes, the bacteria travel from the lower genital tract, bypass the cervix, and enter the normally sterile environment of the uterus. And from there, they migrate up into the fallopian tubes and the ovaries.
And the body's immune system goes to war, basically.
Exactly.
But if it can't kill the bacteria, it tries to contain them. It basically builds a quarantine zone.
That's exactly the right concept. The immune response triggers massive inflammation. White blood cells flood the area, tissue starts to break down, and, well, pus begins to pool.
Ugh, wow.
Yeah. To stop the infection from spilling into the rest of the abdomen, the body attempts to wall it off with inflammatory tissue. This creates what the literature calls a tubo-ovarian abscess, or a TOA.
A TOA.
Right. It is a thick-walled, highly pressurized, massive infection encompassing the tube and the ovary.
Okay, so structurally, how does that translate to the pain of deep dyspareunia? Because if the abscess is all the way up in the ovaries, why does a physical impact lower down near the cervix cause such an explosion of pain?
It comes right back to your suspension bridge analogy.
Really?
The organs are physically continuous. The cervix is the lowest part of the neck of the uterus. The uterus is directly attached to the fallopian tubes, which are draped over the ovary.
Right, they're all connected.
So when a bimanual exam or deep penetration pushes on the cervix, it mechanically thrusts the entire uterus upward.
Oh, I see. You are physically pulling the strings that are attached to this quarantine bomb of infection.
Yes. The clinical term for this is cervical motion tenderness. Moving the cervix structurally stretches the infected, pus-filled tubes above it.
Ouch.
And because an active abscess is engulfed in severe inflammation, those tissues are completely hypersensitive. Every nerve ending is dialed up to a 10.
Makes sense.
Stretching them sends shock waves of burning, agonizing pain through the pelvis. It is a fiery, systemic hypersensitivity.
And that's why the pain lingers for hours, like we talked about earlier.
Exactly. You've mechanically agitated tissues that are already screaming from a severe immune response.
And because it's a raging infection, the patient is going to have other warning signs, right? Like, this isn't just localized pain.
Oh, absolutely.
The case studies mention systemic clues. We are talking about a fever over 38 degrees Celsius or about 100.4 degrees Fahrenheit. There's often an abnormal, purulent vaginal discharge, meaning it contains pus. Blood tests will show a massive spike in white blood cells. And the reports describe these patients using the word prostration.
Prostration is a clinical way of describing someone who is just utterly wiped out.
Like completely exhausted.
Yeah, they are physically exhausted, shivering, completely depleted by the metabolic demands of fighting off a severe, deep-seated infection. The abscess is making their entire body sick.
Now, there was one detail in the guidelines that absolutely blew my mind.
Oh?
It's a complication called Fitzhugh-Curtis syndrome. The infection doesn't just stay in the pelvic web, it travels up to the liver. Like, how on earth does bacteria from the reproductive tract end up attacking the liver?
It's pretty incredible. The mechanism is a brilliant, if destructive example of internal fluid dynamics.
Fluid dynamics in the belly.
Yeah, the abdominal cavity isn't a dry, empty box. It contains a small amount of peritoneal fluid that constantly circulates. It moves up the sides of the abdomen through what are called the pericolic gutters. And this movement is driven partly by the suction created when your diaphragm moves as you breathe.
Wait. So the physical act of breathing creates a vacuum that pulls fluid upwards.
Yes. In some cases of PID, particularly those involving chlamydia, the infected fluid from the pelvic abscess gets caught in this upward current.
Oh my God.
It literally tracks up the right side of the abdomen until it hits the liver. Once there, the bacteria cause perihepatitis and inflammation of the liver capsule.
That sounds awful.
It is. The body forms these tiny, stringy adhesions between the liver and the abdominal wall, often described in surgery as looking like violin strings.
Violin strings. That is wild. So a patient might experience brutal collision pain during intimacy, but they also complain of a sharp ache in their upper right abdomen, just under the ribs.
Yes, or even referred pain in their right shoulder because the liver capsule is irritating the diaphragm nerve.
And all of it tracing back to a quarantine infection in the pelvis.
It demonstrates how a localized structural mass can create widespread chaos. The active pelvic abscess is a hot, spreading, volatile pathology.
Right.
Its pain presentation is rooted in the fact that the tissues are inflamed and hyperreactive.
Okay, so I totally understand how that fiery inflammation explains the feverish, exhausted patients. But what if someone has that exact same collision pain, that horrifying sensation of hitting a rigid roadblock, but they aren't sick at all?
Right.
Like no fever, no pus, perfectly normal white blood cell count. What is going on there?
That brings us to the second mass in our clinical stack, the chronic pelvic hematoma. We are moving from the realm of infectious fire to the realm of silent mechanical pressure.
A pocket of trapped blood. How does a massive blood clot end up taking over the pelvic suspension bridge?
Well, a pelvic hematoma originates from vascular trauma. It is not caused by ascending bacteria at all.
Okay, so it's a physical injury.
Right. A blood vessel deep in the pelvis, often a branch of the pudendal artery, ruptures and bleeds into the surrounding tissue spaces.
When does that happen?
This is relatively common after operative childbirth, like forceps deliveries, but the sources emphasize that it can occasionally happen after a completely normal vaginal delivery.
And the bleeding is entirely internal, so the patient doesn't even see a hemorrhage.
Exactly. It frequently occurs in the supralevator space, which is just above the pelvic floor muscles, or inside the broad ligament, which is a fold of tissue that holds the uterus in place.
Okay.
Because these are confined spaces, the blood pools. Over time, the liquid blood goes through a physiological process called organization.
Organization.
Yeah. The body's clotting factors weave a net of fibrin, trapping the red blood cells,
Yeah.
essentially turning this pool of liquid into a dense, solid, fibrous mass.
Wow. So it goes from a puddle of internal bleeding to a literal brick of clotted blood wedged next to the reproductive organs.
The literal brick is a good way to describe it.
That completely changes the structural presentation. We aren't dealing with inflamed, infected tissue anymore. We are dealing with sheer physical displacement.
Exactly. The mechanical presentation of a hematoma is relentless, heavy pressure. The symptoms reflect a physical blockage.
Like what kind of symptoms?
Patients report persistent perineal pain, a dragging sensation, or a profound fullness in the rectoanal area. Because this dense mass is taking up so much space, it literally pushes other organs out of the way.
Oh, man.
It can compress the urethra, making it impossible for the patient to pass urine. It can press against the bowel, causing severe fecal impaction.
There is a case study in the reports that paints such a clear picture of this. It involves a 31-year-old multiparous woman, which for anyone listening means a woman who has previously given birth.
Right.
3 hours after a seemingly normal vaginal delivery, she develops discomfort so severe that she physically cannot sit down.
Just immense pressure.
Yeah. But when doctors examined her, they didn't find the heat and swelling of an infection. They documented a fullness felt in the left fornix.
And just to clarify, the fornix is the spatial recess right next to the lower end of the cervix.
Right, thank you. So she had a massive organized clot bulging into the vaginal canal. Now, imagine a patient with a chronic, undiagnosed version of this attempting intimacy.
It would be excruciating.
The deep dyspareunia here isn't caused by pulling on an inflamed, infected tube. The penis is physically colliding with a dense, unyielding block of clotted blood that has warped the anatomy and is actively compressing the surrounding nerves.
And here's where it gets really interesting, structurally speaking. The abscess demands attention. It sets off systemic alarms with fevers and chills.
Right.
The hematoma, however, is often described in the medical literature as silent.
Silent. That is terrifying.
It is. If the bleeding is slow and contained deep inside, there is no outward sign of trauma. Instead, the signs are hemodynamic.
Meaning related to blood flow.
Exactly.
Mhm.
If a patient is actively bleeding into this hidden pocket, they might present with sudden dizziness, pallor, or hypotension, which is a dangerous drop in blood pressure.
Because they're losing blood internally.
Yes. Blood work would show a drop in their hematocrit, which is the volume percentage of red blood cells.
They're slowly bleeding out, but because the pelvic suitcase is zipped shut, the blood has nowhere to go but to expand and crush the internal organs.
This requires a highly tuned clinical suspicion from a physician. The deep dyspareunia caused by a hematoma is a structural roadblock causing tissue distension and nerve compression.
Yeah.
If a doctor only screens for infection, asking about fevers, or running a swab for bacteria, they will miss the solid mass of blood entirely.
So we have two totally different villains, a fiery infectious abscess and a silent, heavy, bloody hematoma.
Both very dangerous.
And they both cause excruciating collision pain. They both occupy the same tight real estate. So how do doctors at the diagnostic crossroads figure out which one is pulling on the suspension bridge?
It is a notoriously difficult clinical challenge. As the sources point out, a manual pelvic exam is severely limited. The doctor's hands can feel a general fullness. They can locate a tender mass. But human touch cannot easily differentiate between a dense capsule of pus and an organized block of blood through the thick vaginal wall.
A lump just feels like a lump.
Exactly, which is why advanced imaging is absolutely critical. Ultrasound is typically the first line of investigation, but an MRI is the definitive gold standard for categorizing complex soft tissue masses.
Because it can see through the tissues.
Right. Magnetic resonance imaging uses magnetic fields and radio waves to map out the exact chemical makeup of the tissues.
And the radiological reports detail exactly how these two masses light up differently. Like an active abscess shows up as a thick-walled cystic structure.
Yeah.
The radiologist can see internal debris, and the surrounding tissues will show bright signals indicating severe edema or, fluid swelling from the inflammation. But a chronic hematoma paints a completely different picture.
Yes, it does. On an MRI, an organized blood clot will demonstrate high T1-weighted signals.
T1-weighted?
Yeah, in the physics of an MRI, the way the magnetic pulse interacts with methemoglobin, which is a byproduct of decaying red blood cells in a clot, produces a very specific bright white signal on a T1 scan.
Oh, that's clever.
It tells the radiologist definitively, this is not fluid, this is not an active infection, this is decaying clotted blood.
So what does this all mean? Why did we just spend 15 minutes dissecting the physiological difference between internal blood and internal pus?
Well, it's crucial for the patient.
Exactly, because if you or a partner are experiencing deep collision pain during intimacy, you cannot accept a vague catch-all label of chronic pelvic pain as the end of the road.
No, absolutely not.
It is a symptom. It is the suspension bridge sounding the alarm. You have to push for the imaging. You have to advocate for the MRI because the structural mass hiding in the dark could be actively damaging your internal organs.
And if we connect this to the bigger picture, the danger of a misdiagnosis at that crossroads is profound. Imagine a doctor assumes a heavy, silent hematoma is actually a mild pelvic infection. They prescribe a standard course of antibiotics.
But antibiotics are completely useless against an organized blood clot. The physical roadblock stays put. The nerves stay crushed.
And the patient suffers needlessly for months. Conversely, imagine a doctor assumes a localized pelvic mass is just a benign cyst or a small, self-resolving bleed, when in reality, it is a highly pressurized tubo-ovarian abscess.
That's a ticking time bomb.
It is. If they treat that with just painkillers and a wait-and-see approach, the outcome can be fatal. The abscess wall could rupture under pressure, spilling highly infectious, necrotic pus directly into the abdominal cavity.
Which leads to sepsis, right?
Exactly. Peritonitis, systemic sepsis, and severe morbidity. It is a life or death imperative to accurately identify the source of the spatial disruption.
We've covered a massive amount of ground today. We open up the complex, tightly woven suspension bridge of the human pelvis to see how it reacts to foreign invaders.
A lot of hidden architecture in there.
Definitely. We establish that deep dyspareunia is the mechanical alarm bell sounding when those internal structures are compromised. Right.
And we contrasted the fiery, hypersensitive, infection-driven pain of a tubovarian abscess, where every movement sends shock waves through a quarantined bomb of pus, with the silent, heavy, nerve-crushing pressure of a chronic pelvic hematoma. Two vastly different pathologies hiding behind the exact same physical symptom.
It really highlights just how intricate and sensitive internal human anatomy really is.
Yeah.
But before you finish, there's one final provocative concept I want to raise.
Oh, let's hear it.
It stems from a brief mention in the sources regarding something called Levator-Ani syndrome.
Levator-Ani syndrome. That's a condition where the muscles of the pelvic floor go into a state of painful, continuous spasm, right?
Yes. And it forces us to look at the intersection of structural anatomy and neurology.
Okay, I'm listening.
Consider a patient who experiences severe collision-type pain from a hidden abscess or a hematoma. They feel that agonizing impact during intimacy for 6 months, maybe a year, before they finally get the MRI.
They finally get the surgery, the mass is removed, the infection is cleared. Structurally, the pelvis is completely healthy again.
The boulder has been completely removed from the webbing.
Exactly. But what has happened to her nervous system during that year? The human brain is a predictive machine.
Oh, wow.
If you repeatedly experience severe, blinding pain during a specific physical action, the brain learns to anticipate it to protect you.
So it braces for impact.
Yes. Is it possible that the brain's subconscious anticipation of hitting that hidden mass causes the pelvic floor muscles to permanently lock up in a defensive spasm?
That makes total sense.
Meaning that even after the structural mass is entirely gone, the pain of deep dyspareunia remains, driven purely by the neurological muscle memory of the trauma.
Wow. So the physical mass rewires the nervous system. The ghost of the abscess or the blood clot continues to haunt the muscles long after it's been surgically removed.
Exactly. It's a sobering thought.
That is an incredibly powerful thought to mull over. And it just proves that you cannot wait. You have to listen to your body and act early when the mechanical alarm bell rings.
Absolutely. Time is of the essence.
Do not let your pain be dismissed as a mystery. Demand the imaging, ask the hard questions, and find the structural truth. Thank you so much for joining us on this deep dive into the hidden architecture of the human body, because at the end of the day, when it comes to your health, you deserve to see exactly what is hiding in the dark.